Now the session is open for discussion. I invite all the four speakers, Dr. C.M. Kumaran, Dr. Gopalakrishnan N. Dr. Fijad Innar, and Dr. Muhammad Tanveeruddin Shelle onto the dais.
So let me start the discussion with a question to Kumaran sir. Sir, that's a nice detailed talk. So what is the treatment that you advise for many a time you get patients who are delayed, come 4 to 6 weeks after local massage treatment for the base of the thumb fractures. So what is the treatment you advise in such cases? Coming after massage treatment or local massage after 4 to 6 weeks, base of the thumb fracture.
What type of fracture you mean? Extra-articular or
Intra-articular or any fracture. Take it intra-articular.
extra-articular fracture, if it is united with less than 30 degree, you accept that, there is no problem.
Intra-articular, suppose it's intra-articular. Is there a role, displaced type, is there a role for osteotomy or you go for a fusion or something like that?
No, I think there is no role for fusion. Okay. You go for an osteotomy and fix it through the fracture.
Okay, sir. Any question to Kumaran sir? So what are the basic views that you advise for a base of thumb fractures that everybody should be knowing?
The true AP view of the thumb.
And then how do
it is not the true AP. If you take the AP of the wrist, it will not be a true AP of the. It will be an hyperpronated position.
Yeah.
That is one view, which will give you a correct idea of the base of the shape and the articulation will be seen. The other one is the true lateral view, that of the that's also a pronated view. These are the two basic views. In addition, in some cases you may require a traction X-ray or a CT scan. Oblique view, if necessary, you can go for an oblique view also to assess the fragment.
So true AP view, how do you take it? The thumb, true AP view.
True AP view is in a pronated position, thumb in pronated position. Okay. Like this.
Robert view.
Robert view.
Okay. Thumb in hyperpronation.
Hyperpronation.
Okay.
So how often would you advise a conservative management for Bennett's, like a cast application?
Bilateral Bennett's fracture. At present, we are not doing conservative treatment for Bennett's fracture. That is not advisable.
I think the close reduction won't stay, even in a cast.
Close reduction and percutaneous fixation
would be the first line.
Yeah.
Okay.
But AO reference says conservative treatment for also described there. I don't know whether it is being done or not now.
So that's what I was asking. If the patient presents laced to you after 3 to 4 weeks with a Bennett displaced, not a significant step but some step, can we accept that or we should go and re-osteotomize it? So it's always better to.
I think we should not accept that because especially it happens in a young patient like this, it will definitely go for a OA changes soon. So and a malunited Bennett always gives a lot of pain when the patient uses a thumb. So that, because majority of the action is, movements are happening at the CMC joint. So there will always be pain when there is a malunion. So it should not be accepted, the malunion with a more than 2 millimeter displacement. Better to go for a corrective osteotomy if it is like 4 weeks, 5 weeks. You don't come with close reduction and percutaneous fixation. You'll have to openly reduce it and fix it.
Okay. There may be problem of adduction of web space contracture also.
So when you fix the fractures, we will be mostly targeting the joint or the fracture or both. So you told that all the three methods are there, but in your experience, have you changed from fracture, from the dislocation to fracture, or you're doing both?
Both should be corrected. Articular surface
fixation
continuity will be important.
Fixation and fixations, when you're fixing it, should we fix when the wire is put? We'll put only for the joint, or we'll fix the joint?
The transfixing wires can be put into the trapezium. It will not cross the trapezium. From the metacarpal to the trapezium, from the metacarpal shaft fragment to the trapezium can be put. It need not go through the fracture. If it is very small fracture, only 2 pins, one from the metatarsal to the trapezium and another to the base of the second metatarsal is sufficient. Metacarpal is sufficient.
Question to Dr. Tanveer. Is there a role of a dorsal approach and dorsal plating in today's scenario for Laurent radius fracture, or everything you can manage with volar?
Yeah.
plates?
You can manage the dorsal fragment from a volar approach using a fixed angle plate, especially with the variable angle plate. But the problem is you have to bring the plate more towards you have to cross the watershed area. If the fragment on the dorsal surface is very small, you have to have a bicortical purchase there, right? So that produces problems. That can produce a tendon rupture that is reported in the literature. Okay. To address that problem, previously, as the plating started in 90s, it was initially the dorsal column fracture, dorsal approach plate. The plate size was bigger. So all those produced extensor tendon problems, then that concept that came into disrepute. Okay. To address that problem, the size of the plate is reduced. So with the small 2.4 plate which is available with the AO, the incidence of the synovitis is reduced. It is not 0%, but it is significantly reduced. So still there is a role of dorsal approach in distal radius fracture even now. So for that, this one we have this fragment specific plates.
Can you combine K-wire with volar plate? For suppose there is a dorsal combination. Is it advisable?
Yeah, you can combine, but you keep the K-wire. When you keeping the K-wire outside the skin, probably that is a risk for infection. That is also described. But when you apply a K-wire, the K-wire, if there is a dorsal combination, if you apply a K-wire, the K-wire has to be buttressed, otherwise it will collapse, right? So that for a certain extent the collapse can be prevented by your volar locking plate. But in spite of putting a volar locking plate from the volar side, collapse can occur. That is described.
For the fixation, when we are trying to do an intra-articular fixation, what is the best method to see whether the joint is congruently reduced? So
Radiograph.
only radiograph can. Is it possible that you said that the volar ligaments are very
You
very
can have
important?
arthroscopic assessment,
Yeah.
but there is no evidence to suggest that arthroscopy is better than fluoroscopy. In fact, the evidence for fluoroscopic assessment is moderate than the limited evidence for the arthroscopically assisted elevation.
But at no point you should not should be doing an arthrotomy and opening the capsule and see it from outside from.
The capsule, the anterior the capsule is the strongest ligaments in the carpus. So you should not disturb that, because once you do that, the morbidity of the patient will be very high. So never incise that and try to see it. That is you cannot see the ligaments from outside. These ligaments can be only seen through the arthroscopy from inside. That is actually thickening of the capsule. You cannot see that ligaments from outside. So when you cut the capsule, you are cutting actually ligaments.
Okay. Question to Dr. Gopalakrishnan. So what is the approach for a transcatheter balloon? You go volar, dorsal, or you go combined?
When you have a median nerve problem, definitely you have to
Go volar.
Otherwise, standard is dorsal approach. If you want, you can combine it with a volar approach, depending on ease of.
So first you always go dorsal. If there is no middle complication. What are the KYs? What are the important KYs that you need to fix them?
First, you have to, if it is a transcatheter, pure lesser arc injury, you put the lunate in relation to radius and fix it, and then steps.
So is there a wire connecting radius to lunate or a capital lunate?
Radius to lunate,
Okay.
and then scapho lunate, scapho capitate, trichotrochanter.
You maintain the radio lunate wire or you remove
It
it?
is unstable, better to maintain it, or it is kept as a till you work up the other.
Yeah, that's what I was asking. Okay.
In late percentage cases of transcatheter balloon distribution, will you always try dose reduction first?
Beyond 3 weeks, I don't think it will work. So you have to open it, sir. Mostly transcatheter, you have to open it, reduce the scaphoid. Only fresh cases it will come with dose reduction, around 10 days also.
Okay. In scapholunate dissociation, only KY fixation is sufficient, or you have to reconstruct the ligaments in a fresh case?
I have few cases I have done just close method,
Yeah, that's right.
just KY fixation, and most of them have not come with problem to me. I don't know whether they have gone somewhere else, but this thing is you have a lot of secondary stabilizers. Maybe the secondary stabilizers are intact, and this ligament injury.
So only
gets
K-wire,
repaired.
close K-wiring is
Do
enough.
some rehab, they'll get away.
Okay.
Is there any time frame for the reconstruction? Or
Yeah, beyond 6
do you
weeks.
see the quality of the ligament or any time frame?
Beyond 6 weeks, healing potential is less. So you have to have some augmentation.
Suppose it is an avulsion, do you go for reconstruction or?
No, if it is repairable, you don't do it. But if not, do a capsulodesis or a terodesis.
So rather than a period, do you see the quality? That's what I mean.
Yeah, that's it. On table, you can decide.
Dr. Pija, nice talk on DRUJ, I think.
Thank you,
It was
sir.
very good for all the PGs and consultants. Just one question. You see, whenever you see a ulnar styloid fracture with that lower and radius fracture, you are always go and fix? Or
Actually,
what's your take on it? Because many times we find it commonly with the lower and radius there is a
the thing is like mostly we don't fix the radius. Actually, we had done a study from like our own place only with the ulnar styloid, and what we seen is if you don't fix the ulnar styloid fracture, in the long-term study, if you take the modified DASH score, about 60% is only giving a fair results. They're not providing a good results. So according to modified DASH, it is fair, good, and very good, excellent. So if you don't fix it, it is reaching merely a fair result. So ideally, it has to be fixed. So ulnar styloid, if it is displaced, means to get a long-term results, what the study shows is it has to be fixed.
okay. It's
All levels.
No sir, basically the ulnar styloid avulsion, usually it may be a ulnar styloid base. So that will be usually associated with the avulsion of the TFCC also.
Classically, we were all taught like that. That is, if the tip of the fracture, you can just leave it like that. The base should be always fixed. But there is no evidence, currently there is no evidence to suggest that if you fix the base fracture, in all the fractures, that gives a good outcome. That is the current recommendation. So whether there is actually studies are there, randomized control studies are there, which says they compared both fixing and not fixing this. But currently the evidence to suggest that the fixing of base of the your ulnar styloid fracture gives a good result is not correct. That is actually they told there is the evidence to suggest that fixation is not there. What currently they recommend is at the end of the surgery you see the stability of the DRUJ. If it is unstable, you fix it. If it is not unstable, you just leave it like that.
So what is your take on that? On current thinking on ulnar styloid fixation?
Yeah, I mean, if you go look at the evidence, it's there for both sides.
Yeah,
Right. But basically, yes, clinically unstable at the end of the surgery with an ulnar styloid base which is displaced means we know that there is a soft tissue injury there which is pulled off the ulnar styloid, which is the TFCC. Now, after restoring all the indices of the distal radius, does it become stable? Yes, it can become stable because there are secondary stabilizers. One of the secondary stabilizers you have taken off when you are doing volar plate, which is your pronator quadratus. Which means if you can repair the pronator quadratus back nicely, that is one stabilizer you are putting back. Next is the intraosseous membrane. You can't really see the intraosseous membrane, what's happened to it. The third is the ECU sheath, which we don't open up on the side, but it could be injured along with the TFCC. So you have two things which you can't see, which is the intraosseous membrane and the ECU sheath, which are the major secondary stabilizers. One, you have heterogenically you have removed when you are doing a volar plate, which is the pronator quadratus. The third is the ulnar base, which is displaced, which we know indirectly could be TFCC. Either you scope and look at it, or you assume that it is injured. Now at the end of the surgery, what all can you restore is your result, or a functional result, right? So you have restored the distal radius completely and the DRUJ has come back to its normal position. That is the first point, okay? You will be able to cover the plate and put the pronator quadratus as a second point. Once you do that, you check for instability. Then if the instability is still remaining, you know that probably the TFCC, the intraosseous probably are still not, they are still damaged and you can't restore them. So as a surgeon, I would feel safe that if the base fracture which is displaced, I can fix it. So at least I'm taking care of one more thing, which is the TFCC. and also immobilize for 3 weeks in whatever way. Pijat showed the K-wire. I can just put it in an above elbow slab for 3 weeks for me to allow the intraosseous membrane and the ECU sheet and other things to heal. So if you go this way, then your patient might do well. Okay. So again, we just concluded a study on all these 3 components, and they show that definitely that 3 weeks of immobilization initially would be good enough for the soft tissues to heal. So you don't have to aggressively go and mobilize just because we put a oral locking plate. So components which are in our hand to control, we should control. Then you see instability. So the caveat is still that instability should be there at the end of surgery for you to go on to any of those things. Very aggressive surgeons might go and repair the TFCC arthroscopically. We would just put a wire through the ulnar styloid, but it should never be a closed pinning. It should be always a percutaneous open pinning, not a percutaneous pinning. You have to see the styloid because the dorsal sensory branch of ulnar nerve is there. So you should not be doing it percutaneously. That's one thing I can help. But open up, put the styloid back, fix it nicely. So you've taken care of one more variable there. Right? Rheumatoid sometimes you might not be able to suture if it's badly lacerated. So you need to take off all the variables of instability. Then only I think you can. That is the logical way of doing it.
So fixing it with a single K-wire is enough, or you have to go for these?
As long as you get a good reduction, it's fine. It's
single K-wire. Yes. You bury it or keep it outside.
You call it again all surgeon's choice, but not never percutaneous. That's what I'm trying to check. It's an avulsion fracture, so which means you have to reduce it. The strong TFCC pulling it, so you have to under mission reduce and put a wire and hold it nicely.
You have to put additional DRH K-wire also after fixing?
Not necessarily. If you just put a above slab in supination, 30-degree supination, it should be not full supination, just about 30-degree. It should settle down nicely with it. Dorsal, just dorsal here, small incision, additional incision.
A single K-wire is enough.
Okay. When you're doing dorsal approach, you have to be careful not to open the ECU sheet, or it's
ECU sheet you just have to retract there. You don't open it through. But the most important, the nerve would be the dorsal sensory branch of the ulnar. Yeah. So you should not give additional problems to the patient by doing percutaneous and then you'll cause neuroma there.
So this DRH K-wire is what is the ideal size that you say? Talk it was told 1.2. Is it
1.2 is
enough?
But you're not leaving the patient alone with that. You have to immobilize.
Okay. How long you maintain this DRH?
3 weeks.
3 weeks. For montage, for Galeazzi and everything?
For everything 3 weeks.
Yeah. Single wire is enough or 2 wires?
Single wire is enough. One of the safest ways to put it to come out on the other side also. So if at all it breaks, you can remove it from one of the side. Otherwise, that's one technical.
We usually put 1.6. That's why I asked you. Too much. 1.2 is enough. Single K-wire.
Yes.
Okay, sir. Thank you. Are there any more questions? Otherwise, we can wind up the session.
So for Tanvi sir, for the volar Barton fracture, what is the implant of choice now? Do we use volar locking plate, or is it Ellis plate? Non-locking plate is still okay for?
You can put a non-locking plate if the fragment is big. Finally, that is the area where your ligament attaches. Okay. So if the fragment is good, big one, you can buttress with your non-locking plate. Basic issue is buttressing that. It is not locking or not locking. You have to buttress that fragment. If you cannot buttress with that, if the fragment is small, you may have to use that pin plate or something like that. Or you can tie that fragment through in the present place you have got holes to tie these fragments there. You can take a bite through that and tie there. You can manage with that.
So we have a distal radius fracture, we have fixed it, there is DRUJ instability. You also see an ulnar styloid fracture, you fixed it with the K-wire and you still feel there is some instability. What do you do next?
That's what we told you. If there is an instability, you have to address that problem. If there is a styloid process, you fix the styloid process.
Even after fixation of the styloid?
Then you transfix the distal radioulnar joint with the K-wire and immobilize it for 3 weeks.
There is no role of any acute assessment of any other ligaments, the ROJ?
No.
Okay, sir. Thank you.
Thank you. I will invite our chairpersons, Dr. Sibin Surendran and Dr. Vijay sir, to give away the memento and certificate to our speakers. I invite Dr. C.M. Kumaran sir, Dr. Gopalakrishnan ML, Dr. Fijad NR, and Dr. Muhammad Tanviruddin Sharma. Thank you, sir.